Welcome to those of you who have joined us this morning. Many of us are here early, and some of us have yet to join. But in the spirit of respecting Sherborne Standard Time, it's my pleasure to welcome Dr. John Halamka, whom most, if not all of you, know very, very well. John has served with MHDC as the co-chair of our CIO forum for many years. I think, John, probably close to 20 years. John has also been instrumental in advancing the consortium's knowledge of how regulations, especially those related to high tech and the Affordable Care Act, influenced the emergence and funded the emergence of electronic health records and the subsequent efforts on the part of the federal government to determine how well people were using them. Without further ado, and without any further discussion, quickly note that the splash screen shows you Mayo Clinic and Dr. Halamka's Twitter handles, as well as hashtags for those of you who are tweeting and are interested in reading tweets about today's discussion. That's the information that we are sharing with you. And with that, John, I will turn it over to you.
Ryan, thanks so much. And so great to see you all again. Everybody's looking good. And the one thing that's true about MHDC, Danny, is none of us ever age. You know? And the only reason that I have different glasses is because my whole life for the last year has been 24 inches from my face, right? So it's like, who knew that we would be together running innovation across the world from sitting in an office, not in fact going out in public. It's what a year it's been. So as folks know, January of 2020, I went from Boston and Harvard to Mayo Clinic. And there's a reason for that. And so let me just sort of give you the mechanics, just because you're all my friends. And as Denny said, we've worked together for 2 decades. In August of 2019, Gianrico Ferrugia, the new CEO of Mayo Clinic, posted the following job description: wanted physician engineer with 30 years of digital transformation experience, extensive international travel, writing and speaking, apply within. And so you read that job description, and what you recognized is the phenotype was about 3 humans.
Yeah.
And so, you know, it was so strange that I had to apply. And so I went to Mayo Clinic and I met with everybody. And what I found was a couple of fascinating. So first, you may know Mayo Clinic, founded 154 years ago, was founded on the idea the patient always comes first. And so it's interesting because sometimes, you know, in our various organizations, oh, the professor always comes first, or the provider always comes first. So it's interesting that the entire 70,000 person organization makes every decision based on what the patient needs right now. So that was intriguing. But culturally, what that means is that when you talk about innovation, there isn't the William Gibson, oh, disseminate, you know, the future is here. It's just not, you know, evenly distributed. It's the whole organization just moves in to innovate because the patient demands it as a unit. And that doesn't mean it's top-down command and control. I mean, there are multiple sites in Rochester, Arizona, Florida. Each of them has independent innovations and that kind of thing. But what it means is that it is a culture that is ripe for change and agile to implement change when the patient will benefit from it. So there's sort of this intriguing alignment of events, right? That you've got a organization that decided that by 2030, it's going to be the world leader in digital health and providing not only the capacity to do digital health inside Mayo Clinic, but actually for the whole world. And so that's what this position I took is really all about. It's externally facing, creating innovation with collaborators and partners. In fact, even empowering Mayo's competitors with various types of technology that will fundamentally change patient experiences everywhere. It's not limited to the United States, and it's not limited to specific business lines that Mayo is currently supporting. So it's a very intriguing set of ideas. And so today I thought what we do is go through, what has this first year look like? What are those first things that we did, and how did those experiments pay off or not? And what do we see the next year or next 6 quarters doing? So, but first, Denny, let me start with, people don't even know what a platform is. I mean, obviously we use the term platform all the time, and you got the platform revolution, and every startup says, oh, they're a platform and that kind of thing. So I'm going to use the strangest example probably that you can imagine, because welcome to Unity Farm Sanctuary and my office here. So if you look over my left shoulder, what you're going to see there is a clock. That clock is an intriguing clock because the weights in the clock are liquid mercury, not exactly very environmentally sound. But here's the story on this clock. So it was 1905, and an engineer in his basement in Armonk, New York, said, I have this idea for a business platform. And the idea is they're going to be mechanical devices, but we're going to automate them. And that way we can take human labor out of things like winding a clock. So this particular clock, when the weights get halfway down, a motor that he installed kicks in and automatically winds the weights. So in fact, this is a perpetual clock that runs 24/7, 365 for over 100 years with no human intervention. And he said, so this idea, he called the International Time Recording Company, because the idea is you could build these automation platforms by taking mechanical devices and adding motors. But then after that, he said, maybe we should move on to punch cards and maybe automate reading of that. And, it's a bunch of machines. So why don't we rename the company the International Business Machines Company? And so this is actually Thomas J. Watson's clock. He signed it, and it was, believe it or not, dumped off in an antique store in Waltham in 1996 that my wife happened to be running at the time. So I tell you that story because what you see is someone had this idea of automating manual processes and doing it for all kinds of devices, and that became a platform for what IBM evolved into, from clocks to computers and services. So at Mayo Clinic, what we decided to do was we looked at the entire healthcare system and said, well, what are some of the kinds of common things that people need to do, but they're hard? And how do we automate those and make them a repeatable process that's extraordinarily agile? And so we'll get to the slides in a second, I promise. But let's just imagine this. Have any of you, payers and providers, been asked, can you share data with a collaborator? Because you're going to develop a new AI algorithm or a new analytic or a new tool, new visualization, new workflow. And the answer is, of course, all of you have. And it takes 18 months. And it takes a team of lawyers. And in fact, it may be that there are more lawyers than programmers. I mean, that's just sort of the nature of the process of sharing data. So Mayo's first question was, John, can you take 154 years of Mayo Clinic data, 5 EHRs, all of the structured and unstructured data, all the images, all the omics, all the digital pathology, everything that we've gathered from a telemetry point of view, and place them in a de-identified secure container in Google Cloud, right? So we have this joint venture with Google, and then make it such that any collaborator that we wish, whether it's an entrepreneurial company, a payer, pharma company, et cetera, can access that corpus of data in a privacy protecting, ethical way in literally a day or two. And it's just a process, right? It's no different than an assembly line. And so here was our challenge. Starting in January, which is when I started, we asked the question, what's de-identified data? And that's, of course, a tricky question, because HIPAA could tell you, oh, just remove the 18 identifiers. If you remove Denny Brennan, Waltham, Massachusetts, okay, then it's de-identified. Well, maybe, because, let's just come up with some strange examples. What if the patient is on a medication that only 12 people in the country take? Or what if the patient is 150 years old? Or what if the patient lives in the Murdoch Antarctica ice station, right? I mean, you sort of just think about all the things that may not be in the 18 HIP identifiers, but create a bin size of a very small number of patients, not exactly de-identified. So we partnered with a Kendall Square-based company called Inference. And what they do is they look at the data. Not only do they look at structured data, but they look at using NLP, unstructured data, and then create bin size representations of the characteristics of each individual, and then make modifications, redactions to the data so that the bin size of any one individual's longitudinal record is 10 or greater. So if I just said, oh, here is the record of a person who's involved in an IT convening organization. Well, right, there are enough of those that would be sufficiently de-identified. And so from January to April, we took 10 million patient records and worked on the structured data, the problems, the meds, the allergies, the labs, the usual US CDI kind of stuff, and moved that into Google Cloud. And before anyone gets worried, no, we didn't give it to Google, right? What they see, it's sort of a non sequitur here, but Ascension said, we're going to take our entire corpus of patient identified data, hand it to Google engineers under a BAA and ask for their help. We didn't do that. Didn't work out so well for Ascension. It's sort of funny, mechanistically, we actually moved the data first to Azure, and then in Azure ran all the de-identification algorithms. And then Brad Malin from Vanderbilt certified that the data in Azure was de-identified at a level that far exceeded anything he'd ever seen. And then we moved the de-identified corpus of data into an encrypted container on Google Cloud, for which Mayo holds the keys. Google doesn't even have the keys. And that was important because and I said the word Google, so my phone is, of course, asking, what do you want? So when I went to the Wall Street Journal, the New York Times, Washington Post, it said, we've got a secure container. We have the keys. Google doesn't. It was de-identified before it even arrived there. And we never exfiltrate the data out of that secure container. We simply invite collaborators and partners into a subtenancy of our cloud where they can go run an analytic tool or a visualization or an AI algorithm validation, but they can't actually get the data. It's never, ever leaving our control. And the general response by the public and the press was, okay, de-identified better than anyone has ever done, encrypted at rest and in motion, under your control, and all you do is allow novel, innovative tools to use the data set in your container and only take out knowledge, not data. That actually sounds okay. And so again, January, April was the 10 million structured records. Then it took us a little longer, till August, to deal with 10 million unstructured records. And Danny, I'll send you the preprint paper that we submitted recently on this, because it's really hard. I mean, we are unaware that anyone in history has taken 10 million longitudinal notes, reports, free text, and de-identified them to a level that truly you can't discriminate an individual's note from 10 other people's notes. And that was pretty tricky. So that was done.
Can I ask a question?
Oh, sure, please, go ahead.
Why is 10 a sufficiently large number? I mean, if there's 10 people that are 105 years old in the world, I could say, well, it's John or Denny or Arlene, or I can't say which one of those people it is, but that seems like a small number.
Fascinating question that you ask. And so what we did, because what is the community standard for bin size? There is no community standard for bin size. So we asked every government on the planet what they, from a regulatory perspective, believe is a de-identified good enough kind of thing. And interestingly enough, even within the federal government, we got 5 different answers. In the US, what we got was Devin McGraw, who of course used to run the Office of Civil Rights in the Obama administration, told us that the most severe restriction was at CMS, where CMS had a bin size of 10 requirement. So you're right, it's a little bit arbitrary, but it was based on regulatory constraint internationally and the highest level of bin size in the US federal government requirement currently.
That's also what the state of Massachusetts has set for their bin size for using the state data, whether it's all payer claims or hospital case mix data. They have the magic 10 number.
But there's a little, I think, John, a little bit more than that. One of the things that we've also said is, 10, okay, it's regulatory perspective good enough. But you have to do 2 things. First, remember not letting the data out of this secure container, which means you absolutely prohibit linkage of the data to any other external data source. And you have a data use agreement that, of course, says you who are using this will never attempt to go do what you just said. I'm going to go look at all the 105-year-olds and I'm going to go figure out, if there was one that may or may not have had a medical condition or something like that.
So just to clarify that in my head. So your agreement with the consumers of the data are that I, as a consumer, would never try to look at that, say, 10 record set or bin and go, oh, it's an obscure disease or accident. And if I Google it, I could see a newspaper article where, John, I'll use myself. John Juris, got a tree branch through his skull and whatever that's coded as. Oh, it must be John. That particular record must be John.
And here's what's fascinating. The way we've set up the certification for this data with Brad Malin is this certification necessitates that the data never leaves the secure container, because then you start running into the problem you've described. So this is a bit different than the LaTanya Sweeney example, where it's like, oh, it's a state database and anyone can download the whole thing. No, you can't. Like you could even say Brad Malin wouldn't certify it as sufficiently de-identified if it was let out in the wild.
Got it. Thank you.
Sure. In December, we moved 200 million DICOM objects into Google Cloud. And here's this sort of interesting, as you think of a DID, de-identification of structured data, not so hard, unstructured data, pretty hard. What do you do with images? And you say, oh, well, that's pretty straightforward. You just remove the metadata on the DICOM header. Well, okay. But there are lots of X-rays that have a little lead imprint on them or a patient card or something like that. So you got to, oddly enough, do optical character recognition and determine if there was any kind of imprint on the X-ray. But then it gets weirder. What if I have a de-identified head CT or MRI? Okay. Maybe they're 3mm cuts of a patient's face, and all I have to do is a 3D reconstruction of the slices and facial recognition, and then I know who the person is. And you say, oh, that's just science fiction. Well, we did it. 27% of the head CTs can be re-identified using 3D reconstruction and facial recognition. So what do you have to do? Again, this gets a little far-fetched, and I'm just telling you my experience. So we worked with Google to develop an algorithm that reduces the voxel height of skin to 0. Now, what does that all mean? What it means is the bone windows and the brain windows, they're all intact, but the face becomes unreconstructible because the skin layer on the CT and the MRI is reduced to 0. And so that, again, as you look at each domain here, you have to decide what your de-identification strategy is going to be. And that's what we decided on images. Omics, this one was tricky in two ways. So if I took my 3 billion base pairs and I made them available in a database, I think most would argue that that could be re-identified. In fact, we've seen examples in ancestry.com where criminals have been identified by relationships because of genomic data posted on ancestry.com. So you could say it's pretty re-identifiable. Well, here, you'll love this, Denny and John. When I went to government lawyers and said, how do I de-identify the genome? They said, oh, that's easy, because the 1996 HIPAA rule doesn't say anything about the genome, and therefore it's not PHI. Well, I also told them, well, in 1996, it didn't say anything about flying cars nor the internet. I mean, just because it wasn't a 1996 thing doesn't mean we have a free ride. So what we decided to do was two things. We would apply the same bin size idea, not use full genomes, but use biomarkers, SNPs, segments of the genome that were common. And as an example, so I carry BRCA1. I mean, the good news is my daughter doesn't. But there are lots of males that have BRCA1. And of course, it's going to be relevant because you worry about descendants then having a higher risk of breast cancer. So it's okay if you look at a bin size of 10 to have BRCA1, but not my full genome as part of an omics representation. So that's what we did. Bin size of 10, SNPs, biomarkers, and that kind of thing. But then there's another question, and that's the ethical issue. And Danny, I can share this with you. It's just a draft. But Mayo is convening in April an international meeting of 100 thought leaders to look at consent and what it means to truly have informed consent when your data types include omics. And so again, I'll make this up, and I see Dave Delano and your lovely picture there. If Dave was asked to share his flu vaccine status, he'd say, who cares? Of course. Hey, Dave, I want your entire genome, which will express all your proclivity to disease in your life. Oh, well, that's a slightly different issue. Consent's more complicated. And so what we felt was we needed to rewrite the Mayo consent so that we can, going forward, prospectively ask patients for consent for secondary use of their data for data types that may have different cultural or ethical consequences. And lest you think we went nuts, there are only 5 choices, right? Not 100. And the intent was to say, we would like to use your genomic data for discovery and new treatments, yes or no. And, we would like to use it for research in the following way, yes or no, right? So it's just a couple of choices where you indicate your preference. We did it not only because 5, the patient can mostly understand, but also it's 5 that we actually felt we could implement. Because if you start saying, oh, well, you can do line item redaction of your problem list or your medication list, or I like this doctor, not that doctor, it's impossible to implement and enforce. But pretty straightforward. If the patient says, no, I don't want my genomics data used, then their genomics data is not included in the de-identified database. It's just sort of a binary thing. So we'll see how that all goes. The draft we think is pretty good, but we're going to get this international input, and we have to reflect on things, not just HIPAA, California Consumer Privacy Act, but also the general data protection rules, and try to make this an internationally consistent consent. And then next area of adventure is digital path. We have 30 million glass slides, and it turns out Google has a number of algorithms that allow you to do morphologic search on digital pathology images. And interesting thing about this thing I've been telling you about, it's basically exabyte scale. I mean, to give you, since this is the Mass Health Data Consortium, a sense of just how you have to think a little bit out of the box. When I moved those 200 million radiology images into Google, we then ran some models on them to classify them that required 20,000 TPUs running for 6 weeks. And then again, from a Google perspective, applying 20,000 64 core servers to a problem, well, that's just something you just gin up and down. It's not a problem so much. It wasn't very expensive either. But that's as you start to think about these massive data sets and creating these next generation AI models and classifiers and such, it does go wildly beyond any institution's capacity to do this. You really need to do a partnership with a Microsoft or an Amazon or a Google in order to get it done.
Can I ask
Oh, please go ahead. Go ahead.
a philosophical question? I'm trying to steer clearly away from any political. Do you think that, in other parts of the world where they don't have these same debates, around privacy of this information, that will lead potentially to competitive advantage, I'll say, in medicine over some period of time?
So what a brilliant question. And so let me answer this directly. And, I recognize it's being recorded, but I travel, well, at least in 2019, I traveled quite extensively. I tell people, well, I did 400,000 miles of travel in 2019, and I was in every country other than Iran and North Korea. And so what you see is societies have such different privacy, cultural expectations that there are societies for which, well, it is a societal benefit to aggregate and analyze data, and therefore we're going to do it. And it's interesting. I mean, there's probably different flavors of that. Like when you visit the Nordics, right? Or let's take Iceland, right? Everybody in Iceland, 250,000 people, said, well, of course we're going to assemble the world's largest genomic database of the time because it's going to benefit society, right? It was everybody all in for society, as opposed to there are other societies that say, we're going to gather this and don't bother asking.
Right. We're just going to do it.
Right. So you're right. I mean, there's potential for certain societies to be able to generate algorithms or generate analyses faster than we can in the US. But here's what I would argue, is that we were able over this last year to create novel technologies to do this, that it's IP that others don't have. And when you look at this paper that I'll send, Denny, you'll see that we achieve levels of sophistication that go a factor of 10 beyond anything that's ever been done before. And so maybe our innovation will outstrip any slowness because of our attention to privacy. So I think it'll be okay. Well, I was just talking about digital past, so that's kind of an interesting one, because what's de-identification of digital pathology, right? And we do have to do optical character recognition because sometimes there are no patient identifiers numbers written on the slide, so we can do that. But hey, these are Denny's macrophages. Look at that, I recognize them, right? So at the moment, with the state of the art, even though there is morphological search, we aren't really believing that you have to do something like redaction or pixelation or something like that on digital pathology. But who knows? I mean, right, that may come because the bin size question may be real. But that's the next thing we're doing. And just to give you a sense, and we've partnered with industry to do this. And do you remember how the genomic sequencers used to work? They used to take here's your big DNA, and we're just going to start at one end and we're going to go to the other, and it's going to cost $100 million and it's going to take years. Well, then we decide, oh no, let's take a piece of DNA and chop it up into lots of little bits. And then we'll sequence little bits, and then we'll reassemble those little bits mathematically. It's very cheap. It's very fast. Well, we've partnered with a company that has invented a digital pathology slide scanner that does the same thing. It just in parallel, massively parallel, scans little bits of the slide and then reassembles them. And that results in a high resolution image done much faster and much cheaper than traditional technologies. The challenge with that one is then what data format do you use? We ended up putting all of our digital path into DICOM. And I tell you, this is like a detail probably way beyond most folks would care. But if you look at the digital pathology nascent companies, the standards haven't really been declared yet. And there's a proprietary standard called a Perio. There's just lots of variations out there, but it's pretty clear the direction is going to be DICOM, just as you had for radiology devices. Digital path will end up in DICOM. So we chose to use that. And interestingly enough, the data that we end up storing for all of this structured and unstructured, all this information I've been telling you about is natively stored in FHIR format. And you say, wait a minute, why would you do that? FHIR is an over-the-wire API transactional standard. Well, that's true, but it's also a schema. And so we have chosen to standardize our storage at rest for all of this de-identified data in a FHIR form. And it's turning out, it'll be interesting, that a lot of companies are starting to develop tools to be able to ingest FHIR data natively and then be able to provide manipulations and model development from it. So this, was, Danny, quite a long preamble, but this thing that I've just described is called the Clinical Data Analytics Platform of Mayo Clinic.
Hey, John, John Kelly, good to see you again. That's on that FHIR, storing as FHIR. I think a couple of years ago, Graham Greene had written a few pieces about FHIR's not really a great standard storage model for querying data. I've heard about a lot of progression in how that's being handled. A lot of people making pitches about using the FHIR repositories for analytics. Are you actually running the analytics on the FHIR data, or are you transforming the FHIR data for the purposes of the analytics and the queries?
Right, the latter.
Okay.
So when you look at companies like Smile CDR, right, the idea is that the CDR is storing things in a FHIR format because here's a challenge. We are dealing with so many historical EHRs and so many variations in data types. How are you going to create the world's most standard universal schema?
Right.
That was the problem. And so storing the data in FHIR as a data model, and then the tooling can read it in that format and transform it as it needs to, seems to be a reasonable strategy. And that's, I was like you, I was like, are you sure? And Josh Mandel, who, many of us know, who's now at Microsoft and has done quite a lot on the Argonaut project, said, it actually seems to be a direction to store it in a CDR in that form and then transform it with tooling from that CDR.
Perfect. Thank you.
John, just Joe and Bimbo, great to see you again. Been a while. I have a question for you. You're investing in an awful lot of time to try to harmonize all of this data. Is there a assumption that you're going to make these investments because you're actually looking for some kind of outcome, or you're doing this sort of to let the world go crazy on the data set to find out new things about people in the population, the old pop health on steroids type of scenario? I'm just curious about where do you think this is going to go once you get all this data harmonized into the cloud?
Okay. So let me, because again, it's among friends here. Let me tell you what I was charged to do. Obviously, we want to create new cures and new treatments. We want to empower payers, providers, pharma, and everybody to do goodness. But at the same time, we want a business model that creates value for Mayo Clinic, because we believe by 2030, reimbursement is going to be such that unless you have intriguing new business models, it is going to be hard to sustain your mission. So yes, folks, I was charged with Mayo's currently an $18 billion company. I was charged with creating the digital functions that will be 30% of Mayo's revenue by 2030. So let me give you some examples of both what we've done technically, but also then what we've done from a business perspective with this data set that I've described. So Inference, this partner we used for de-identification, has a business model of being the sandbox or the query front door for the pharma industry. So Pfizer or J&J come to Inference and say, oh, we are trying to develop a new drug. Oh, we're trying to subset a drug so that we get the right patient population where it'll be effective. Oh, we want to do post-market vigilance. And then Inference goes into our container and answers those questions with the 10 million de-identified records that we have. And Mayo is a partial owner of this company. And so there is an equity value increase to Mayo Clinic because we're now providing this discovery kind of service. And see, what's interesting, again, the ethics of this, right? We're not selling data. We're not exfiltrating data. It's if Pfizer says, is this a good drug target? And we answer yes or no. So that's been one use. Another use, K Health, which is an Israeli company recently valued at 1.4 billion, said we developed ways for healthcare. And that is the care journeys of patients at Maccabi are something they used to develop AI models, big HMO in Israel. And that's great if you're Israeli, but how does that model work in the US? So K Health asked if they could be a subtenant of the data and develop ways for healthcare on the 10 million Mayo patients. So now when a patient, say in the US, says, I woke up this morning with cough and fever and fatigue, where do I go? What do I do? And then K Health is able to say, oh, well, we've looked at 1 million patients like you, where you live, the time of year, and this is the journey you should go on. And that, turns out to be, again, a benefit to patients. Diagnostic Robotics, a very interesting Israeli company who, oddly enough, Joe, works with payers. And here's the interesting issue. Did you know, Joe, that only 60% of people with depression are helped by SSRIs? And so what that means is that Tufts today is throwing away 40% of the cost of SSRIs given to people for which they have no effect. Problem is you don't know which people. And so again, Diagnostic Robotics then works with payers to say, can I decide for a given drug? And even if it's a high cost treatment, Tufts would probably reimburse it if it was known to be really, really effective in this very small subset of patients, but keeping the payers from paying for treatments that aren't going to make an impact. And they use our data set. A company called Clue, CLEU. Interestingly enough, last week, the first FDA approved AI cleared algorithm done with Mayo data. So FDA has a nice new program to take a look at an AI algorithm's efficacy and safety, and then actually clear it as they would a medical device. And first one in history was done with Clue and Mayo. This is an ICU escalation algorithm that says, can I predict for a given patient that in the future, 5 hours from now, they're going to have a decompensation? And therefore, let's make an intervention before the decompensation. And the FDA approved that. So hopefully what you see from this is that by building this secure container and then the subcontainers and inviting various kinds of queriers, payers, providers, pharma, startup companies into it, you generate really interesting new products and value But Mayo then is also able to realize equity gains. And they sort of give you a sense, again, my KPIs as a person are, this is very new startup adventure that I'm on, are, a little hard to define, but in our first year, we generated $220 million. So that was probably a good harbinger of saying, creating an ecosystem of discovery and a repeatable process that works across all comers, that's ethical and privacy protecting, is ultimately a good thing as you look at where healthcare reimbursement is going and sustainability of Mayo Clinic. So that, hey, Denny, I just took like 40 minutes to tell you the first business. So here's the second business. Sometimes you get lucky. And in January, we said, I bet virtual care is going to be important, but who wants to compete with American Well or Teladoc? Not my thing. So the question is, what about high acuity care at a distance? Serious and complex care, not just ambulatory care or store and forward of your mole is that cancer. So starting in January, we partnered with Medically Home, which is a Kenmore Square based company. And we decided we would offer a Mayo hospital at home service. And we decided to use Florida and Wisconsin as our two initial marketplaces. So we built a command center staffed with specialists, and we built a set of tools that are all hosted on Google Cloud that include dashboarding, care alerts and algorithms, the ability to manage supply chain and staffing. Went live in Florida in July and Wisconsin in August. And so far, we've discharged 200 patients, high acuity patients from their homes. And a couple of things we discovered. So first, in the first 200 patients, safety and quality are no different than an on-prem hospitalization. And for my colleagues in the payer community, the cost is 1/2 of a hospitalization in a bricks and mortar facility because there's just not all the overhead. So we're able to deliver the same outcomes, safety and quality, at half the cost. So that's interesting. The patient satisfaction scores are astronomical.
We love it. Yeah.
And let me give you some case examples of why that's true. So we had an 87-year-old woman with hyponatremia, serum sodium of 102, and normal sodium's 140, 102. It's really, really bad. I mean, that's serious and complex illness. And she had a cat. And she said, I cannot leave my cat. And so for her, the return to wellness actually depended on the proximity of her cat. And we delivered the same treatment that she would have had in an inpatient setting in her home with her cat. And so it was like deliriously happy. But her spouse told us every time she's gone to a hospital, she's had a big problem with sundowning and needing Haldol or other medications. During her entire hospitalization at home, she didn't sundown once, right? So you've got the comfort of your home, the familiarity of your surroundings. You don't have mental status changes or things that might complicate your hospitalization. So it ends up you get to wellness faster. So that's good. Another case, we had an elderly gentleman who was quite sick with a pneumonia, and his wife was a cancer patient, not with an acute illness, but undergoing chemotherapy. And so you looked at the home setting and you said, well, wait a minute. If we're going to return the patient to wellness, we actually need to support the wife during this particular episode of care so the family returns to wellness. And so what we ended up doing is, since we bring in the meals for the patients every day, we brought in meals for the family and fed the family and brought the family back to wellness, looking at the social determinants of health and what was needed. So I tell you those examples because it's a fascinating thing. When you go into someone's home, you understand how they live, their social supports. Maybe they have issues of safety in the home. Maybe they have issues of abuse in the home. I mean, you have to address all these things. And that's why it has really worked very well.
So, hi, John. Can I ask a quick question? Since we've been talking about privacy and consent, are there additional privacy areas that you need to be concerned about if you're doing stuff inside the home versus other care, even if it's the same care?
It's a really interesting question. I mean, obviously, there's a whole series of consents that are signed. And I am not sure. Let me ask the person who administrates that program if they altered the consent in some way.
Well, we're having Medically Home and Raphael presenting to us in just a couple of months, I believe, as part of our webinar series.
Well, excellent. But I'll ask AJ Dunn, who runs the program, because here's the interesting thing about that question. We have actually found situations where we go into the home and the home isn't safe.
Mm-hmm.
And so we developed a corollary service to our advanced care at home called Care Hotel, where we actually move the family into a Marriott and then deliver the care in a Marriott. And again, at the time of COVID, there were lots of rooms in the Marriott. And so it's sort of interesting because as we think about digital divide and disparities of care, and you say, oh, all you need is a safe, comfortable home with Wi-Fi. Well, then you're suddenly selecting for a patient population. And so the Care Hotel idea is you don't need a home and you don't need Wi-Fi. You know, we're going to do a hotel situation. Again, care is going to be much cheaper, even in a Marriott hotel room, than a hospital. And the patients find it actually more comfortable than a hotel room anyway.
Mm-hmm.
So that particular business, since you'll be talking to Raphael and Remy, we have found that it is a model that has great traction for not only the reduction in cost, but also what we're starting to see is in a time of COVID, there is an expectation by the patient that they can receive a lot of different care virtually. They've tried it with office visits and it's worked. They don't really want to go to a bricks and mortar facility where they're going to be surrounded by COVID patients. And so interesting, we started the program and did no COVID treatment in the home. It was all for patients we kept out of the hospital, and that made them happier. But there are two other consequences sort of interesting. In Northwest Wisconsin, there are a lot of community hospitals. Community hospitals there don't have a lot of capital. They can't build new hospital rooms. So we said to them, well, what if you used your existent medical staff and they practiced at the top of their license and they were able to deliver more care to more patients without capital requiring that you build more beds? And what we actually found is that community hospitals that were struggling can actually do much better financially by simply extending the reach of their existent clinicians. So that was a very important part of the business model. And during a time of COVID, we've seen waivers that have made DRGs and parity for the hospital without walls. You've seen all these waivers and regulatory changes. So that in fact, there really isn't that much difference from the reimbursement of a hospital room and the reimbursement of a home hospital experience. And so, yeah, you'll hear more from Raphael, but the business line that we call advanced care at home will be profitable next year. Right. So that was not an unexpected result, because this was a whole line of business with a capital investment by us in creating a command center. And we didn't quite know if it was actually going to work. And the answer, at least to the first 200 patients, is it works. Patients love it. And based on the scale that we've been able to achieve, by next year, it will be profitable. So that was the second line of business. And yes, we are major investors in Medically Home. And Denny knows I have no conflicts of interest. I mean, I don't own any of these equities or have any association with these companies, but Mayo does own a good portion of them. Third business, and the one that is most intriguing and speculative, is we know that we have increasing amounts of telemetry from the devices we wear and the devices in our home and the apps we carry and that kind of thing. And the question is, what are you going to do with it? And that is, you can, on your Apple Watch, do a lead one ECG and send one every 5 minutes to your primary care doc. And then what? Right? And so here's the question we asked. Could Mayo offer a service of being able to ingest large quantities of novel data types from sensors and wearables and apps, filter the signal from the noise, apply algorithms to the signal, and then provide something of value as a result? So a couple of things we started with. You'll see a paper coming out in the Lancet in the next week or two. We were able to develop an algorithm that can take your Apple Watch lead one ECG and diagnose COVID-19 with a negative predictive value of 99.2%. And so that is to say, well, maybe we can't quite yet say, oh, I'm looking at your Apple Watch data continuously. Oh, you just got COVID. But I can say pretty well that if every morning you wake up, push a button on your Apple Watch, in 3 seconds, I can say you don't have COVID today. And you say, well, that sounds impossible. Well, but here's why it turns out to work. The spike protein, even on the South African, Brazilian, variants, bind to the ACE receptor on the heart and create subtle lead one ECG changes that cannot be detected by humans, but can be detected by algorithms. We took 65,000 tracings to develop this algorithm, and its performance characteristics are pretty good. So imagine you offer as a service, we're going to do, instead of your PCR, your antigen, your antibody test, every morning, you're good to go to work test from your watch. Oh, well, that's kind of an interesting business. Or can we look at voice data and do neuromuscular disease screening on voice data? And
can I back up for a sec? Can I interrupt? Can I buy that yet? We're doing massive testing on campus. I'm curious if I gave everybody a watch, if clinically that would be sellable yet, because it would be cheaper.
So so there's sort of two. I'll just tell you where we are. So we're in the next 2 weeks. We're spinning out a company to offer this and doing the FDA clearance of it.
Got it.
Yeah. So you'll see the paper. The algorithm's done.
Yeah.
The company has been formed. We're just finishing the final, legal issues on the company. And I mean, again, just to sort of full disclosure to everybody here, the idea here is as we develop these novel algorithms, we'll spin out companies, and those companies will take them to market and do all of the appropriate safety, quality, and surveillance that the FDA requires. So
if they'll be applying for an emergency use agreement?
Yeah. So it'll be 2021.
Okay, got it.
Again, this is the sort of interesting thing about living in my current job, is that I almost don't know what every day is going to bring. And it's moving quite rapidly. So another algorithm we've just finished is diagnosis of Parkinsonism and ALS from voice. And it has a pretty high AUC, 0.9. So that you could literally say, Alexa, I'm worried that I am having a problem now. What do you think? And Alexa could come back and say, well, you have a 63% chance of having a neuromuscular disease. We're going to set up an appointment with a specialist for you now. Again, this sounds a little far-fetched, but what's fascinating is as we're looking at these bits of telemetry, whether they're Apple Watches or voice or behavior, we have algorithms that can bring value back to the payer, to the provider, and to the patient. And so this whole line of business has required that we build an architecture. And I'll send this to you, Denny, so you can circulate it. But what this is, I know you can't read any of that, but on the left side, it identifies all the data types that we're likely to encounter in healthcare, whether that is a provider-based device or a consumer-based device. What it is you need to ingest that data, what it is you need to do to normalize that data, because obviously things like ECGs, they're not in a standard format yet. How you then bring it to a secure enclave where you bring an algorithm and the data together and then produce a result and return it in workflow. And so we started with cardiology. We've got the neurology one that's almost done. One that we'll have in another month or two, which is really interesting, is radiation therapy. And let me explain how that one works. So today, who knew that every linear accelerator on the planet has an API, completely standards-based today, that allow the linear accelerator to be programmed remotely with an auto-contouring profile? And the problem with radiation therapy is it requires a physicist and a radiation oncologist. And it's certainly in many locations in the world not so easy to find these people. So what if you could develop an algorithm? We started with head and neck, that the DICOM object of a CT or MRI is sent into this architecture, then brought to an algorithm which creates the auto-contouring profile. And the end result is a linear accelerator auto-contouring program so that Mayo Clinic could literally run every linear accelerator in the world. And do that, obviously there's human review along the way, but what we're starting to see is this process is able to take what is about 16 hours of human time and reduce it to about an hour of human time, because the algorithm so augments the auto-contouring generation and does so with a level of quality that results in a lower radiation dose and fewer side effects. Mayo has just figured out over the time how to create a somewhat novel approach to therapy delivery. So that's coming, and that one is done in collaboration with Google, and Google will host all the componentry to do that. And on and on and on. So there are 200 clinical departments at Mayo, and my role in creating what I have is called a practice discovery process is you go to every practice and say, well, what is your unique capability? Oh, you can figure out ALS or Parkinsonism by listening. Oh, could you turn that into an algorithm? And then empowering them with our large data set that I started with to develop these algorithms that instantiate their specialty knowledge and then are delivered at scale through this architecture that I'll send Denny. So that particular thing I just described is called Remote Diagnostic and Management Platform, or RDMP. We just hired a CEO for a spin-out company to operate a lot of this capability, and that will start next week. And we partnered with some venture capitalists and some existing companies, oddly enough, in Boston. So there is a sort of funny theme here that in this first year, it's Kenmore Square, Kendall Square, and Harvard Square that are powering all these Mayo innovations. But so far, so good. And maybe the last two things to mention, and I just want to say one quick thing about COVID, and let's open it up for questions. So we have two new businesses that will form in 2021. One is an AI validation business. And so I've been working pretty hard on this over the last couple of months. Imagine I develop an algorithm using 1 million Scandinavian Lutherans. And I use that example, it's sort of silly because it's Minnesota. And then we take that algorithm and we're going to run it in Southie. Is it going to work? Too much care, too little care? I don't know. right? So what you need, we hypothesize, is for every algorithm that is developed in healthcare, you're going to need what we call a data card and a model card. The data card says what ingredients went into this algorithm. Did we use Scandinavian Lutherans? What geography, race, ethnicity, age, gender, economic strata, all that stuff. It's the data. The second, the model. What is the model performance across different strata? And it may be fine to develop an algorithm on Scandinavian Lutherans if you're only going to use it on Scandinavian Lutherans. But you should see in the model card that said this is totally appropriate for that subset. Don't take it to Spain. And the problem with algorithms today is there is no data card and model card on most algorithms that we use. And there's no way for the purchaser of an algorithm to validate that they're fit for purpose. So Mayo, with its very large data set and its collaborations, will be working on, in effect, it was like when we certified EHRs, we had testing labs. So think of it as an AI validation testing lab that on any algorithm can produce a data card and a model card. And that presumably will result in a marketplace where then you decide what algorithm you want based on its performance. And last business we're starting, you guys have all worked with Mass Challenge, and we love Mass Challenge. And what you see in so many incubators and accelerators is the companies get to a plateau and then they die, or they just are flat. And that's because they don't have an easy way very often of going from their earliest customers and prototypes to something that is a much larger scale. And trying to do associations with provider organizations for pilots, it's a long sales cycle. It just takes a lot. And by the time you've got the agreement to go forward, the company's run out of cash. So the notion is Mayo Clinic in Florida has this whole incubator function. And we're looking at creating a national collaborative of ways where startup companies that have gone beyond their seed to maybe their Series A, and now they're looking to take the next step, can have a provider-led accelerator experience where, just like data access is within days, companies being able to do pilots in clinical settings could be in days. And that particular business would not only give us sort of first look innovation, but presumably there may be an equity component to that kind of thing too. So that's this Mayo Clinic platform world that I've lived in for the last year, but I've also lived in the world of COVID. And I think many of you have probably participated in some of these activities, where in March of 2020, a number of us created the COVID-19 Healthcare Coalition. Now 1,200 companies working together on everything from PPE and contact tracing, vaccine credentialing, cures, and then something called The Fight Is In Us, which is worked on monoclonal antibodies, convalescent plasma, and hyperimmune globulin. I tell you this coalition story because it's interesting. What I learned in 2020 is that companies that normally hate each other would come together with a sense of urgency and have a very selfless view. We created in these coalitions a set of guiding principles. That means it's societal benefit, hegemony of none. You got to play nice if you're going to be in the group. It will cost you nothing. There will be no legal agreements. And this has resulted in some pretty intriguing things, like Google and Apple coming together to create the exposure notification algorithm that you're seeing roll out in a lot of states, or companies that would normally be fierce competitors, Microsoft and Amazon, Google, Apple, all coming together on an issue. And again, no money's been charged, but hundreds of millions of in-kind services have been provided, and has worked pretty well. And so it's like MHDC. It's bringing people together for communal benefit. Is a model that has really been, in a time of COVID, pretty important. Every single day at 3:00, there is a convening call to look at what are the COVID issues of the day, and then to figure out how these 1,200 organizations can work together to attack it. You'll see on Thursday, we have a major summit on variants and how are we going to respond as a society to the UK, Brazilian, and South African variant. And I don't know if you guys have read the latest papers, but the South African variant at the moment is refractory to all the vaccines. It's refractory to monoclonal antibodies and convalescent plasma. And so the Brazilian and the UK, not so bad. Probably the existing vaccines will do. The South African, it's a problem. And so we probably are going to have to gin up a structure by which we'll do genomic sequencing at very large scale of emerging virus variants, and then be able to identify strategies which could be novel antibodies or new vaccines as we see the emergence of these new variants. And so that, as we, sort of leave you with this maybe positive thought, we'll all work together on this, but lest you think that you're going to be retiring this anytime soon. I think you better prepare for the fact that variants are going to require a fairly protracted response, and that vaccination, good, all the cures, good, but we're going to, as a society, work together on tools like vaccine credentialing initiatives. So you'll be carrying with you your digital yellow card that enables you to go back to travel or back to world events based on what treatments you've received, what vaccines you've received, and the current state of variants and exposure. And I think this is going to last for a long time. And as I told Epic yesterday, as we were talking about integrating new functionality into Epic, this is not a 2021 problem, right? This is going to be not only for COVID going into 2022 and beyond, but other diseases that will emerge will require that we have as part of our care delivery data stream societal resilience tools. And that's an area all of us will want to work on, whether you're a provider, a payer, or pharma. So, hey, Denny, turn it back to you, and happy to answer any questions.
Well, let me first ask the co-chairs of our CIO forum, David Carusio from Harvard Pilgrim and Bill Young from Berkshire Health System, if gentlemen, you have any questions or any perspectives you'd like to share with John.
Denny, thank you. John, I just wanted to thank you for taking the time to come back and do this. It was a fascinating conversation. I'm always impressed by the things you're working on and how quickly you're able to gin them up. And I have to wonder, the size of the budget, the size of the team, and the scale at which you operate is just fascinating. And any more insights, I'd love to be able to follow up with you on that. Very impressive, and thank you for coming back.
Well, certainly. And this is why when Denny said, please come back to your old friends, I said, of course. So what you'll find is I actually am blogging quite a lot now. You'll find a Twitter stream and a blog stream and daily updates and lots of articles. So, trying to be very transparent about this. Let me answer some of his questions quite directly. The team that I have is 30 people. And why did I choose 30 people? It's the Jeff Bezos 2 pizza thing, right? And that is, if you're going to make decisions this quickly, you can't do it by committee. And you can't require this massive consensus over a very large organization. 30 people seems to be about that sweet spot of being able to delegate work, but also do this in a very agile way. A lot of what we've done, you've heard, has been partnerships and collaborations. So yeah, it's a core of 30 people, but it's relying on Inference, which has 200 data scientists, and Medically Home, which has 185 professionals and a number of startups and such. So you can see we're orchestrating a somewhat larger number of folks that are in startup, mostly kinds of organizations, and then used to working on slow cycle times. My budget is about 30 million. I mean, it's not a huge budget, but the one thing that's interesting about Mayo is there's also access to capital. And so the Mayo Clinic Ventures has about 250 million in capital that it can deploy for strategic investment. And so I think the success that we've had has been the ability to partner and to co-invest and co-develop and have the capital facility to do that, recognizing that not everything is going to succeed. And I told the board when I first started, you know that in a venture capital model, 80% of all the companies fail. And so you have to give me the facility. If we're going to move fast and we're going to try to innovate rapidly, to fail. And they actually said, it's okay. So we built a financial model that gets us to 30% of Mayo's revenue by 2030, assuming that 80% of what we do will fail.
Wild.
Fantastic. Great support.
I concur with Dave and John. Thank you so much. Great to see you, and welcome back to join us this morning. You know, a question or really an ask for organizations like mine and maybe many other smaller healthcare organizations. How do we prepare to partner with you? How do we prepare to work in this new healthcare world that we're heading into? Thoughts on that?
Well, absolutely. So people do ask, oh, is this work you're doing for the benefit of Mayo patients and Mayo facilities? And the answer is, well, of course we want that, but we would really actually rather impact the world. Mm-hmm. And so the idea would be, in the case of Medically Home and the work we've done with them, we're making those products and services available to anyone. And I mean, do we have anybody from Tufts New England Medical Center, Denny?
We may, but I'm not certain that we have a registered from there.
Okay. So Mayo Clinic platform ran the Tufts New England Medical Center hospital decanting during COVID. Right. And they leveraged all these platform components in the cloud to do that in association with Medically Home. And so I think as you start to look at the kinds of things that we're offering, understand that they are not meant to be competitive to you. They're meant to be collaborative with you. And we have something called the Mayo Clinic Health Network or Health System, 13 community hospitals, where we're engaging all these community sites that have fewer IT staff or less capacity to do innovation individually. And then they can leverage some of these components that we've made available in general. So absolutely, we're thrilled to work with any of you, payer, provider, and think of this Mayo Clinic platform as a set of tools that we are all going to be able to leverage.
John, I have a question. For what you are doing to become as significant, as substantial a part of Mayo's revenue as forecast, I remember a conversation we had at a CIO forum with you once a number of years back, where you made reference to anyone who thinks that being in the academic health business, with the capital we have, with the bricks and mortar we have, would probably want to re-examine exactly what the business is going to be like going forward. These technologies seem to augur a future where the bricks and mortars that large healthcare institutions carry on their balance sheets are becoming increasingly liabilities, or increasingly assets that are very less and less well utilized. Could you comment about what an organization that has 25% of its revenue coming from activities such as yours might look like in a way that physically is different and qualitatively different from what we see today?
And this is such a great point. So ask yourself, are we going to eliminate the emergency department? Well, how about this? you're still going to have strokes, heart attacks, gunshot wounds, and auto accidents. And I can actually, I mean, it's going to sound a little weird, but I can actually deal with some of that in the home setting. You'll hear from Raphael that he's actually started an ED at home service. But that's going to be for a subset of disease states, COPD, CHF, AFib, stuff like that. So you're still going to need an ED, right? So think about that. ICU beds. Well, you're still going to need ICU beds. Well, what about ORs? Well, again, we could forecast out 20 years. I am working on some robotic surgery things. They're not any time in the near future. So for now, you're going to certainly need your ORs. Ward beds. Probably aren't going to need them. Right? And so you start to ask the question, well, if I have I'm going to go build a ward bed tower. That's probably not a great use of capital. Yeah, think of care at a distance and alternatives that require monitoring and maybe a different set of services than you have today, but don't require capital investment in a building. So, maybe to summarize, the hospital of the future looks like a big ED with a big ICU on top of it and an OR suite.
Right, and that's it. And a whole bunch of distributed technology and partners enabling them to do things that would otherwise have been done in the tower, as you referenced.
Mm-hmm.
Excellent. Other questions from members of our forum for Dr. Halamka?
Hey, John, Joe, and Bimbo, I'm just curious, do you think there, in all of this that you're doing, that you see some kind of upstart that would get as big as Amazon? I mean, just curious in your mind and your vision. Do you think that there is that opportunity for something so radical that would change the healthcare system as a result of what you're doing? Or do you hope that will happen?
Yeah, well, what a really interesting question. And you always hate to bet against Amazon. But certainly, I mean, again, I don't want to say anything politically inappropriate, Denny, but how well did Haven work out?
Not so well. Exactly.
Yeah, and Amazon Pharmacy, I don't know. So at the moment, with the situational awareness that I have, I certainly see low acuity care being very commoditized, and that's fine. So the Walmarts and providers that are providing various kinds of telemedicine, remote diagnostics, that's fine. That's going to get taken care of outside of our healthcare systems today. But the serious and complex, I'm not really seeing being disrupted. And so I think, certainly as you look at your future, there's always going to be a need that is serious and complex specialty care. And that doesn't necessarily mean on-prem. So you can think virtual, but I don't see that being disrupted.
Hey, John Kelly, could you talked a little bit about, or a lot about digital diagnostics, and then a little bit maybe with the radiology treatments on digital therapeutics. What are you doing? Any other things really going into the digital therapeutics realm based on some of this work?
So let's talk about digital diagnostics and digital therapeutics. So Mayo acquired a company called Safe. Again, I'm not here to advertise anything, just to sort of describe the notion of why we did that. Our belief is if you're going to have a virtual visit, you're probably going to want to have the end-to-end diagnostics around that visit done in your home or done in some sort of convenient way. So what Safe does is provides apps for your phone and RDTs that can be shipped to your home. So you have lateral flow assays or other things that you can actually just run the lab tests yourself on your desk and your phone will do the full interpretation of them. So sort of we think on the diagnostic side, it will be increasingly important whether it's a rapid diagnostic test, lateral flow assay, or device in your home to start imagining that patients aren't going to come to the office or aren't going to go to Quest or LabCorp, and they're going to run these things with the benefit of apps that include computer vision and a few other things. So that was sort of one thing. On the therapeutic side, kind of interesting question is, what interventions can we make in the home? And I mean, certainly there are drug infusions, and we've started to ask questions like, can you provide molecules plus sensors plus services to ensure that you're getting the therapeutic you need in the right dose with the right efficacy? And here's just a quick example of what we did there. We have an algorithm that can measure the progression of pulmonary hypertension from your lead 1 ECG. And we've used things like AliveCor, which is the little strip you put on the back of your phone, or SHL telemedicine. It's a wearable 12 lead from Israel. So we can actually say, here is the therapeutic. And now we're going to measure the efficacy of the therapeutic, even for something complicated like pulmonary hypertension, which typically would require a catheterization. We can now, through an algorithm, look at the impact of the medication and titer the dose. So certainly I see things like that. I'll tell you about my wacky dream, and maybe, John, you can go start the company that does this. Denny may know that, you can't pick your parents, and I inherited primary hypertension from my parents. And even though I'm a vegan with a body mass index of 21 and run a farm, I still have primary hypertension. So that means that I have to take 12.5 milligrams of lisinopril every day. Now, you may know there is no such thing from my payer friends here as 12.5 milligrams of lisinopril. I have to take
conversation.
I have to take a pill cutter and chop pills in half, which is not a very accurate way of delivering a therapeutic to me.
Mm-hmm.
So here's my dream. You remember how Hewlett Packard sold us printers for cheap and then gave us expensive ink?
Yeah.
Yep.
Imagine that we have 3D pill printing in our homes. And that every morning I just go over to my 3D printer and my medications have been printed in the dose that I need, and I take them for me. And from a payer perspective, I mean, could very well be this is going to be safe, quality, cheaper, and I am going to be more compliant. So, I mean, again, that's wildly speculative, but I think we all need to ask, we can move diagnostics to the home. What therapeutics can we also move? And what are the technologies we'll need to do it?
And you didn't hear that Amazon Prime's going to offer that next week?
Yeah.
Through Copac.
We'll
So,
see.
John, I have a more mundane question for you, because when you were with us, we were always talking about interoperability. Are you seeing any progress being made by the EMR vendors to share this information? We talk about patient access. We have these CMS rules that we have to create these APIs for patient access to their data and give it to third-party developers. But is there any significant progress being made with interoperability between EMRs, between hospital institutions? We see pockets of this, but I'm not close enough to the EMR developers to know, are they really making inroads in their products to deliver this kind of service, interoperability between institutions, between providers, et cetera? Never mind the payer interaction that we always talk about we need, but just in general to improve access to information for physicians that have to do diagnostics, like the primary care physician.
Yeah, so let me give you a concrete example from last night. So last evening, we had this large call about vaccine tracking. So here's the problem. I got a Pfizer from CVS, and then I got a Moderna from Walgreens. I didn't. This is not true. But, well, how does that end up in the EHR so that the provider who's now treating me for my serious and complex disease knows whether I'm vaccinated or not? So we actually did some numbers last night. So we have 64 different immunization information systems in the United States, unfortunately. But The immunization information systems of the US are many of them connected through something called the IZ Gateway, which enables you to do multiple queries on the immunization information systems. And then Epic and Cerner are connected both to the IZ Gateway and to the immunization information systems of several states. Well, Mayo Clinic, which operates in 5 states, is connected to 5 IISs. And so that means that when you look in your Epic record, you're getting the data from only 5 states. So we asked the question, well, given that we've got Care Everywhere and Commonwealth, what is the gap? If I am seeing a patient who lives in Montana, can I get the data from the EHR of their physician, which was connected to the IIS of Montana? And here's what we found. We only have a 2% gap. 2% of our patients are either outside the IISs that we connect to or outside Care Everywhere and Commonwealth and all the rest. So what that suggests is that means 98% of the time, I can get the data that I need in an interoperable fashion to care for the patient. So I've been pretty impressed as to how Care Everywhere and Commonwealth have come together. Of course, there are still issues. And that is, as you know, the information blocking and the interoperability rule that take effect in April, we're going to now have patients getting more fluid access to their data than ever before. And that's a gap. And there are certain issues where we have not fire enabled a lot of healthcare. And again, so Danny, I'll share this embarrassing truth with you. Back when we put the COVID-19 Healthcare Coalition together, one of the things we had to do was situational awareness of PPE. Who had it, who needed it, who had ventilators, who had ICU capacity. And do you know what interoperable standard we used? Excel.
There you go. It's the industry standard, right?
And so what we had for the first response of COVID was 2,400 sites SFTPing Excel files. And so what we know is if we're going to build the societal resilience, we will now start, we hope, to instrument EHRs and other, say, administrative systems with APIs to discover things like PPE, bed capacity, ventilators, and that's still a work in progress. So fire doesn't solve all problems, but it certainly seems like this API notion is working pretty well. It's now regulatory required. Well, as of April, it'll be enforced. And we got Mickey, who's going to be the guy enforcing it. Yeah.
Right. Right arm.
Yeah. So I feel like we've made progress and the work ahead is pretty clear. And with Mickey leading the charge, he and I were chatting last night. He's really going to do some good things for us all.
So this is Janice Karen again. I have a question about the remote monitoring and devices portion again, and tying that in with some of the health equity, which is obviously a hot topic. Your vision sounds really awesome, but what about people who might have a mobility issue or who are blind or even don't have broadband access? And how do you, the broadband access obviously is perhaps more easily fixed, although still difficult. But how do you see fitting patients who may not be able to easily do every single thing that you want them to do on their own into this model?
Yeah, so what a wonderful question. And let me give you a couple of answers to it. As we build these various capabilities, we always ask about disparities of care, digital divide, and equity. So part of what I wanted to do was create a roadmap to help us understand where in the US we would have some issues. Change Healthcare, again, Danny, not endorsing any company or service here, now an Optum company, agreed to give 31 billion encounter records to Mayo Clinic for free for us to create the largest in history analysis of disparities of care in the US And Tim Souther, the chief data officer, has spent 5 years attaching social determinants of health to those 31 billion encounters. So later this quarter, we'll have, not a complete answer to your question, but we'll at least have a roadmap that starts looking at care delivery in the US based on this Change Healthcare data. You know, they think it represents about half the population of the US. And it will stratify these disparities by race, ethnicity, age, gender, geography, income level, education. You know, we don't have complete social determinants of health data, but it's kind of surprisingly good. It's been assembled from a lot of sources, including some interesting algorithms that assign socioeconomic guesses based on the address of the place that you live. So that'll help us as we think through this. And then our challenge is, what interventions do we make? I mentioned that in the acute care at home or advanced care at home, we do things like assess the home and then move you into hotels if need be. From a broadband perspective, we actually don't require broadband. It's kind of a strange thing, but we put an LTE modem in the home so that we can control the end-to-end connectivity without requiring any home infrastructure, thinking that would be more equitable. But there's still issues of the digital divide and literacy and income, especially as we start thinking about things like vaccine credentials. And you say, it's just no problem, just own an iPhone 12, you're good. Like, no, if that's a requirement, you've immediately created a huge disparity. So the Vaccine Credential Initiative asks things like, how do you deliver this on paper or a card you keep in your wallet? Or how do you support a flip phone? How do you use SMS workflows? So you're correct that we are very sensitive to thinking about how you can reach all those who need the care. And here's Mayo's commitment. So Gianrico Ferrugia, in the wake of the George Floyd murder, created a budget of $100 million that Mayo Clinic has committed to eradicating racism and disparities of care. And I co-lead that effort now. And so we've got $100 million to address a number of these issues, and they are very top of mind. And Mayo is very, very concerned about creating a worsening digital divide and worsening disparities of care unless we are very proactive about it.
Could I just, thank you for that. Could I just ask you to follow up specifically on some of the disability areas which seem to fall off a cliff when people talk in this area? They talk about the racial disparities, the income disparities, some of the other social determinants of health, but I don't hear a lot of people talking about addressing, you know, well, what if you can't actually physically put that device where you need to and you live alone? Or, you know, what if you can't see the information on the phone and the app isn't designed well to work with voice or stuff like that?
You know, a really good question. So here's what Mayo, it's a start. It's not a complete answer to your question, but what Mayo recognized, to your point, is there are many folks who are not going to benefit from this explosion of virtual care capabilities because they don't have the capacity to use the device, or there's configuration or physical limitations. Mayo is launching an initiative. It's coming out of the Mayo Clinic Ambulance Division, but in collaboration with a number of partners, to create a first in this country community paramedic training and certification program to create a new workforce for the home. Part of this was empowered by the waivers we saw in COVID that enables EMTs and paramedics to now work outside of the typical sites of care. It isn't just an ambulance in a hospital. They can actually work in the home. We started exploring the model in Florida, where we're now having these caregivers that aren't doctors, they're not nurses, they're what we call this community paramedic. Part of their scope of training is in the remote patient monitoring device configuration, installation, and support. So rather than partnering with a geek squad or something like that, it's that you've got a healthcare professional who is working in a scope at the top of their license, coming into the home to help with the physicality of the care, the supply chain, and the devices. So that's a start.
Thank you.
Any additional questions for John Halamka?
Yeah, Denny, I'd love to ask a question. John, this is Seth Proctor. Thanks. This was a super interesting discussion and awesome the pace at which you're tackling these things. I mean, it's really, really cool. I wanted to dig into one question specifically. You've been kind of talking about what a lot of us have seen in 2020 and continuing now in terms of really shifting towards much more patient engagement. You talked about consent, you talked about being able to work from home, you talked about all these interoperability standards to make data more available to patients directly. And I think that's a really important theme we're seeing right now. Most of what you've been talking about, I would say, is kind of in the HIPAA box. You've been talking about providers, you've been talking about doctors' offices, hospitals. Can you talk a little bit about where you see the kind of patient engagement model of this going as we start to look more towards maybe the digital therapeutics we're talking about are, from people who are building devices in the FTC world. Maybe I'm sharing data with my, connected device for fitness or whatever. Like, can you talk about how you see that model evolving and kind of where your group is engaging there?
Right. And so certainly I think we all believe with the interoperability and information blocking rule, there'll be increasing stewardship by the patient of their data and their healthcare. And what you hope is that we evolve to a model where a patient can subscribe to a service where they're the steward of their own data and the service is providing them interpretation, something of value, suggesting more than just eat less, exercise more. And just, some thoughts for you on that. So I mentioned some of these algorithms that we've worked on over the last year, of which we got about 30. But some of the algorithms are doing things like predicting disease states that you will encounter unless you make a change in your health today. And so what if you are the steward and manager of your own data and you subscribe to services that help you with interventions, and then you are really taking charge of your wellness? So I certainly think that is something that is going to evolve. We also see that as patients become stewards of their own data, that they may be able to, if they wish, donate that data and observations. And I've been on chatting with multiple startup companies that are what I'll call the next generation of patients like me, where the idea would be that patients are sharing aspects of their care journey that will help others with similar diseases or issues understand efficacy of treatments. And this is a very dicey issue, right? Because you could imagine a patient saying, well, I ate twice my body weight in garlic and my cancer went away, right? So it has to be curated and reviewed and guided and all the rest. But it seems to be a trend. I mean, my father had multiple sclerosis for 23 years and was desperate for sharing his experience in pharmaceutical interventions with others with the disease so that he could understand what worked, what didn't, and the benefit that he would offer to others with that disease would be, this didn't work for me and why. So I am seeing a lot of startups around this idea of patient empowerment, data sharing and control by the individual, and service subscriptions that bring value to that data.
Awesome. Thanks, John.
John, this is Janice Karen again. I have a question on the AI machine learning front, sort of two aspects of the same question. One of the things that I find when I talk to people about this area is that they don't really understand that what you're getting out of an algorithm is a probability. You're not getting a result of a definitive result of, this person has X or this person fits this category. What you're getting is it's, 86% likely based on the data, the starting data, which may be flawed, and based on, as you were saying earlier. So how do you make sure that those aspects of the puzzle are actually understood and taken into account, and it doesn't become, well, we've set a threshold of 80% and we treat everyone who's over that 80% as if they have X? And both on the medical side, and then as you were just raising, some of these tools where patients, if you were to ever make some of these results available to patients, how do you provide that level of education, which is a completely different level of education?
Sorry, I lost my mute button there for a moment. So what a great question. So you're correct. AI is not magic. AI is probability, and AI is only as good as the data set you use for training and validation. And let me give you a perfect example of just how flawed it can be. When I was at Beth Israel Deaconess, one of the things we did is we began running severity of illness algorithms against our EHR data. Folks may remember the meaningful use era in 2009 when we suddenly began doing medication reconciliation. Well, the AI algorithm is just a probability algorithm. It doesn't understand politics or behavior. So what the algorithm said is, oh my God, everybody got much sicker in 2009. Because, in 2008, they were only on 2 meds, and in 2009, they're on 5 meds. I mean, what happened? A pandemic? Right? And obviously, this was a completely anomalous statistical result that resulted purely from a change in the underlying training set. And that's why it's just so important that as we go forward with these AI algorithms, that, as I was getting at, that you have an ingredients label and a nutrition label. What went into it? Where is it useful for purpose? And then, as you say, there's a huge educational component too of being able to understand what it means. And let me give you a quick example. So Denny knows, in fact, I mean, all of you probably remember when I talked about my wife's breast cancer experience, and she's doing fine today. But she was put on, as many women are post estrogen positive breast cancer, anastrozole, this aromatase inhibitor. And for anyone who knows anything about aromatase inhibitors, they are just awful.
They are awful.
Awful. It's like, oh, you'll live longer, but you're just going to be in pain, you're going to be fatigued, and all the rest. And so we had this fascinating discussion with the oncologist. We said, show us the evidence of the difference between tamoxifen and aromatase inhibitors. And he said, do you know the literature shows you have a 0.3% increase in survival rate if you go to an aromatase inhibitor? And once my wife saw that, she said, like, what? I'll live to 90 in pain, or I could live to 89 and a half in joy? Why would I take an aromatase inhibitor? That's completely insane. And we don't often share that. Every patient will have different values. And I think that we're going to your point, have to ensure that these AI algorithms not only have ingredients and nutrition labels, but then a lay interpretation so helps you understand what is the benefit and what are the risks of this recommendation, because otherwise it's just going to be, as you say, fake news or rumor and innuendo, and that's danger.
We are coming on 15 minutes before the hour, and mindful that we, in a Zoom world, tend to meet back to back in this day and age. I want to reach out to the group and ask if folks have any more questions in the time that we have.
Yeah, hey Jenny, John, it's Dave Delano. How are you?
Great.
Good to see you. Yeah, I put my picture up, but I'm really still sporting my COVID hairstyle, and I just don't want to freak anybody out. But the question is related to real-time diagnostics using this platform. Have you guys started to pursue anything along those lines? And is the data adequate, reliable, and is it available, quickly enough to be able to do that in the acute care setting, or even in the home care setting, for that matter, if you're collecting that data?
So what a really great question. In this diagram that I'll send Denny, which again, you can circulate to the group, here's the challenge. And the answer is, yeah, we've done it. But the data that is coming out of most of these sensors is not following any accepted international standard. Mm-hmm. And so what we've had to do is do things like ingest a live core and SHS telemedicine and other kinds of telemetry, and then do a normalization into FDA XML, and then take that FDA XML to the algorithm, and then produce a result. So the couple of things that we've done, atrial fibrillation, not diagnosis, but prediction. Turns out we have an algorithm that can look at your future development of AFib based on telemetry you give me right now. Hypertrophic cardiomyopathy diagnosis and ejection fraction measurement from ECG telemetry, which again, you'd say, wow, that's kind of strange because EF is usually an echo, but we can do it with a pretty high AUC from real-time telemetry. So, I mean, a couple of things it's required. Normally, our healthcare IT systems are not set up for high volume continuous data. They're usually discrete data or chunks. So we've partnered with a company, again, Denny, not advertising anything, called Commure, Commure. And Commure was founded by General Catalyst, our friends in Harvard Square, to deal with the issue of ingest of real-time continuous high volume data and normalization so that the external partner is doing that hard work for us. And therefore we can just focus on the algorithm development and algorithm delivery rather than the tricky engineering of that. So at the moment, cardiology has been the use cases we've explored, and that's all in production at Mayo today. In fact, I just, for fun, I got an ECG in the basement of the Gonda building just to see how it all worked. And I got real-time interpretation and all these body parameters based on AI models running in real time on my ECG. So good news is I'm low risk for everything.
Well, that's awesome. Yeah, that's awesome. And with the, the explosion of fit apps, in particular on the iPhone or the Apple Watch platform that does the real-time ECGs and people using those, I use mine regularly when I'm out in the backcountry or doing whatever I'm doing, would be able to, sort of capture those events and do some sort of alert or notification of, hey, you had an abnormal ECG on your last journey up, up the trail, what's going on, and have somebody be able to respond to that.
Well, exactly. But Denny also mentioned something important, which I actually like to reflect on with the group, is that because this group of 30 folks that I'm now overseeing is doing their work by Zoom, and we have people in Boston and people in La Jolla, California, and people in Oklahoma, and we're all doing this remotely. I've set up a series of what I call Zoom hygiene guidelines. So first, no meeting lasts longer than 45 minutes. I mean, that is, you don't set up hour meetings back to back, to Denny's point, right? You set up these 45-minute meetings. So there's always a 15-minute break to catch up on email and that kind of thing. And I made an exception for Denny because he's Denny. 45
I'll observe this standard on an ongoing basis after that. Thank you for.
Right. So you do 25 minutes of a half an hour, 45 minutes of an hour. You do that. No more than 6 hours of Zoom in a day. Because even with the breaks, 6 hours, it creates this accumulated fatigue. And then we established something we call email-free Saturdays. And so we are not allowed to send each other email. And, the answer is, of course, if somebody's dying, be intelligent. Right. But just to send I've written this 27-page report that I need you to look at today and send it on Saturday is just something you just don't want to do.
Poor form, right?
And then finally, you'll notice something, Denny, kind of interesting. I have not once checked my email during our time together this morning. And this is because we've established a no multitasking rule. And the reason that we've done that is we discovered when everyone was trying to do texting and email and Zoom simultaneously, I mean, not only did their meeting participation diminish, but at the end of the meeting, they were so fatigued because your attention span was fractured. And so what we've said is the turnaround time, or the SLA, on emails is now allowed to be 2 days. It's okay. You don't need to answer my query right now. And so that's how we've you could figure out, I've actually stopped all caffeine consumption, and so far so good. I haven't gained weight during COVID. I haven't developed a substance abuse problem. And I would tell you a lot of this, I think, requires good COVID hygiene as we work remotely.
Great advice.
Well, in the spirit of that hygiene and recognizing that we can return 10 minutes for the members of this forum to return to their emails and the work that is at hand. John, I want to thank you on behalf of the CIO Forum, our co-chairs, Dave Carusio and Bill Young, and the members of MHDC. It's always terrific to hear what you're working on. It's delightful to hear your perspectives, your insight and ingenuity and innovation are always exciting and help set a North Star for many of us when it comes to navigating new regulations, new technologies, pandemics, and the like. So please accept our thanks and gratitude for joining us today. Please send me. I have a copy of a document that you've sent earlier that I will distribute to the group. If you have anything else in the course of our discussion that you've referenced, please do send that, and we will take care of it from there. And good luck on this colossal but momentous venture that you're undertaking. It's very exciting, and we know the right person's in the right place, and with Mickey where he is, we're feeling like we're putting some very good people in some very important positions, and we're grateful for that.
And let me make the offer to you. You guys know how to find me. And so that means anytime you have a question, an issue, I am thrilled to help in any way I can. So don't be shy.
And with that,
Thank
ladies
you.
and gentlemen, we're adjourned. Thank you all for your compliments.
John.
Stay well.
Thank you, John.
And
Thank you.
we'll talk
Have a great day.
Take care,
You
everyone.
too.
Bye.
Bye.
Thank you, John.